Hello everyone, welcome back to Hot Seat. I'm Omid Moghaddas joining you from Tehran, and once again, so happy to have this platform to share with you with great friends, educators, and lecturers from around the world. And today, I'm so happy to be the host of a good friend and a very talented surgeon and dentist. Dr. Dean Licenblat is here with me from beautiful Australia. Hello, Dean, and welcome to Hot Seat, my friend.
Hello, Omid. Look, it's great to be on here, and I really appreciate the invitation.
Thank you so much for accepting. And over the past sessions, as you all know, we try to cover almost all aspects in implant dentistry. We talked about bone, we talked about soft tissue, the prosthetic, how to manage the tissues, and how to make our treatment outcome as predictable as possible and stable for long term. But as you all know, when we are treating our patients, sometimes things doesn't go the way that we want, or sometimes we have limitations. Sometimes we should think out of the box, and there are some innovations, some new ideas that come to our minds. Sometimes they're simple, but we don't think about them. And today, I'm so happy that my dear friend Dean decided to talk about this topic, which he called it pushing the biological envelope. And I'm not going to go to the details, but he told me that what he wants to talk about, so I want to make it a surprise from his side. And I'm pretty sure you will all enjoy what he will present. And I'm personally super excited for those two cases that he will present for us. And we will have a great discussion on the topic at the end of his presentation. So I'm not gonna wait you all much longer. And Dean, the platform is all yours, and we are ready for your beautiful presentation. But wait, I forgot.
Okay, great. So
we have a routine before we start. I would like to first have a short CV of you, and then please share your screen. Dr.
Sure.
Dean Licenblat has been in private general practice in Sydney since graduating from the University of Sydney's dental program, and has also completed his Bachelor of Science with honors in microbiology. He also holds a prestigious master's degree from the Goethe University in Frankfurt with a focus on oral implantology and bone grafting. As a diplomate member of the International Congress of Oral Implantologists, ICOI, the highest ranking achievable, Dr. Dean Licenblat, together with Sydney Dental Aesthetics and Implants, is one of the few dental surgeries to be awarded leading implant centers of the world. He is also treasurer of ASID, which stands for Australian Society of Implant Dentistry, and a senior tutor for the master's program in oral implantology for Goethe University in Frankfurt. Many of the Australian dentists graduating from the program the past few years have been fortunate to have him mentor and guide them. As a member of numerous dental societies and an unparalleled dedication to continuing education, he often attends post-grad educational programs both locally and abroad, the results of which are integrated into practice, thus offering patients the most technologically advanced and effective long-term modalities. Once again, I'm so blessed to have you, my friend. So we are ready, and you can share your screen.
Thank you, Omid. And with regard to that continuing education, I really hope that one day I can catch a course in Iran and we can hang out and have a meal.
Sure.
So let me share the screen with you. Okay, so let us. Okay, so thank you for having me on the hot seat. This is a picture of me. And the title of my talk today is Pushing the Biological Envelope. And what that essentially means is reaching into the bag and using techniques that you don't use all the time, but are there for those really challenging patients and those really challenging cases. Now, I know for the majority of what we do, socket grafting and simple implants and even full arch can be pretty much bread and butter for the majority of the people out there doing implantology. However, along comes a case from time to time that really makes you think outside the box, and you really need to draw on different places and different courses you've been to where someone might have said something that you've put in the back of your mind thinking that you'll never use that, or it's just something that's not going to apply for you or you don't need to worry about. But then along comes a case and you really need to dig deep and find that. And you'll have to maybe even have to reach out to the person that you spoke to originally and use this technique. So the first case I want to go through is a palatal approach sinus augmentation in combination with a zirconia implant. So I don't know if many people know, but I actually do quite a lot of zirconia implants, and I do that because of my patient base, and a lot of my patient base are holistically minded, so they do want metal-free implants. And this first patient, that's not actually the case, but she needed it because of her medical history. And the second case, actually, the patient opts for a zirconia implant. This is the initial presentation OPG of the patient as she came to my office. As you can see, she's missing predominantly the upper left first molar, and there's a couple of teeth that are missing and some teeth that need some work. So she's a 54-year-old female, non-smoker, non-car. She takes a lot of medication, both prescription, over-the-counter, and herbal remedies. Taking the oral contraceptive pill, and nor does she have any hormonal therapies. Medical history includes lupus. So already a red flag went up for me with respect to the soft tissues, with respect to periodontal disease, peri-implantitis, things like that. So that was something that was already on my radar from before we started treatment. Thyroid disorder, so I had to be mindful about anesthetics. She's on long-term cortisone treatment. It was ongoing, so therefore I had to be mindful about her immune system, her healing. Now, this was the biggest issue for us, was that she has this type of psoriasis, which is actually acute generalized pustular type of psoriasis. It's quite a difficult name to pronounce, but essentially what happens is if she touches something that she is deemed allergic to, her whole body will actually shed several layers of skin, and that's from head to toe. And it's extremely painful and essentially leaves her with majority of her skin actually just coming off and being exposed, essentially. She has extreme metal sensitivities as determined by her dermatologist. So she is seen by a team of doctors, and before we did any treatment, we made sure that we dotted all our I's and crossed all our T's to make sure that the patient was safe to proceed. She had an allergy to Plaquenil, which was not an issue for me. And like I said, written approval to proceed from her general medical practitioner, multiple medical specialists, including her allergist, dermatologist, and immunologist, to make sure that the products that we were using for all the way down sutures and the retraction techniques and everything that we did had to be cross-checked. On examination, she was missing multiple mandibular and maxillary premolars and third molars. Her occlusion was fine. Periodontal probing depths and her actual periodontium as a whole was within normal limits. And she had actually excellent oral hygiene. Very, very compliant and motivated patient, but highly phobic. And she required IV sedation for all aspects of treatment. Her chief complaint was the missing upper left first molar. It was an aesthetic and a functional deficit for her. She had difficulty eating, but for her, the main driving was that you could see it when she smiled. Now, she presented requesting metal-free solution, and that was based on the recommendations of her immunologist and dermatologist. Now, when we took the cone beam, thinking, yeah, that's okay, we can do that implant, no problem. This was the coronal slice of the cone beam. And as you can see, there's a nice thick part of the layer or the buccal portion of that sinus, which is good, healthy, high regenerative potential bone. And in order for me to do an implant, it just wasn't going to work. If you have a look at this from the axial slice, you can see how far that bone extends, and you can see the position of that implant, the position of that bone is half where we want that implant to be. So from a coronal cross section, this is essentially where we wanted that implant to be. And you can see majority of that was inside bone, and part of it was outside. And I just didn't feel comfortable doing that as a transcrestal approach. Now, I know when I first put this case out onto social media for critique, a lot of people said that they could have done that with transcrestal lifts and things like that, using denser burrs and what have you. I didn't feel comfortable that I could adequately get 2 millimeters of bone circumferentially around that implant solely using transcrestal technique with or without denser burrs. I also felt that doing a traditional lateral wall from a buccal approach sinus lift was not going to be easy given the shape and the anatomy of this particular sinus. So I would have to cut the window quite high up, and I didn't have any confidence that I would be able to adequately lift the Schneiderian membrane and navigate that anatomy without perforation, especially getting up and underneath that where it drops off. So with respect to sinus augmentation, we know that traditionally it's a surgery performed to increase subantral bone with subantral bone volume actually at or prior to the time of implantation. Now, the first lateral window approach was actually performed in 1975 by Hilt Tatum, and it was first published by Tatum and Boyne in 1977, which is 1 year before I was born. Now, this evolved actually into the transcrestal approach by Dr. Robert Summers in 1994, which is not that long ago if you actually think about it. Majority of the guys that we talked to and the guys that you've had on the hot seat were actually well into practice in 1994. And you know, this actually really progressing at rapid speed. And in fact, you can see that just on social media alone, as well as in the lectures where you've got things like the Nova Bone Liftoff, where, you know, even within 2 millimeters or 3 millimeters of bone, you can put an implant which will hold a molar quite comfortably, knowing the techniques that we've got, that we can have successful sinus lift. So coming back to this case, when I looked at that, I just didn't feel it was appropriate to do either of those. So I went for a palatal approach sinus augmentation. And this was a technique that I learned from Radoslav Jadak, who's an oral surgeon out of Poland. So I did his course, and it was just something that he'd shown. It was an off-the-cuff kind of case presentation that he'd shown. And I looked at that and I thought, that's really cool. I don't think I'll ever do that. It's really challenging. It's something that I'll probably never do, but, you know, good on him. That's awesome. But as it turns out, the indications for palatal sinus approach, and this is something that he was actually saying, was one, insufficient subantral bone. So you could do a palatal approach sinus lift for any case if you wanted to. Thick buccal bone, which is actually the case here. You can see it was, for me, I felt it was wrong to cut through all that buccal bone just to lift that little bit of palatal sided sinus to get to that, to destroy all that good good healed highly regenerative bone. Just to do that small bit of sinus, I felt was not a good treatment, wasn't very clinically sound. So the other indications for palatal approach sinus augmentation include unfavorable anatomic variations of the maxillary sinus, and that's usually large PSAAs, or previous insufficient sinus graft. So where people have gone in a lateral approach sinus, done the augmentation, but not extended it all to the medial wall. And in doing so, they've got essentially pretty much the shape of the bone like what I have here. Large diameter, unfavorable position of the posterior superior alveolar artery, and acute palatonasal, that's which you can see here is not the case. These were my measurements before I went into surgery. So I had to estimate where about roughly the greater palatine artery was going to be. And we know that generally from the CEJ, it's about 12 millimeters, give or take, according to the Journal of Oral Maxillofacial Surgery. So this was my pre-op photograph. Now, please note on the buccal, there is a soft tissue defect prior to me touching the patient. Now, these photographs are not the greatest. They were from a little while ago, and hopefully my photography has actually increased in the quality sense. My initial incision, as you can see here, the incision is circular from the palatal around the molar, crestal along the edentulous space, and then as I went circular around the first premolar, and then I went actually straight across the papilla. I didn't include the papilla in between the premolar and the canine. And the reason I did that was based off some of the teachings that I got from Howard Gluckman, where he was taking palatal blocks. And in fact, there we go. Next slide here is the full flat reflection. Vertical release is medial of the canine. And the reason that it's indicated to go here is that the greater palatine artery, the extension of that is pretty much at its thinnest in between the premolar and the canine, and any blood vessel extensions from the nasopalatine canal is also thinnest at this point. So it seems to be the right place to drop that vertical. Going distally, I think, would have been catastrophic. This is the full flap reflection. You can see how far you need to extend in order to get good A, visualization, B, access, and to be able to get your instruments in there. This is the antral access window that I created, and I did this using the Neobiotech all sinus kit, of which I use the LS reamer, which is the lateral sinus reamer. It has drill stops, and the bone that we knew was around 2 millimeters. Now, the reason I like these particular burrs is that they're based on neurosurgical burrs. So essentially, they cut laterally, and as they cut, they collect the bone and create a little disc ahead of the bone. So it actually pushes, as it cuts the bone, it makes a little disc and it pushes it ahead of itself. So therefore, the probability of you perforating the sinus membrane in this case, but the dura in your surgical arena is significantly less. And because it has drill stops, I set that to 2 millimeters, and I was able to cut the bone, access the sinus with minimal trauma. In fact, the sinus membrane was not perforated in this situation. Here you can see the Schneiderian membrane dissection, and it's partially elevated. It is a little dark, but you can imagine trying to get the camera in there and trying to get the flash in there is incredibly difficult. And that's full membrane elevation. And that was done with a combination of irrigation and hand instruments. Now, the hand instruments that I decided to use for this particular case was a combination of the ones that come with the Neobiotech kit, but also I got a kit from Dr. Stiller, who's in one of the papers I mentioned later on. He has a sinus lift kit which allows you to fully bend and fully customize any of the instruments. And in doing so, allows you to really navigate the sinus and the anatomy of the sinus as you wish to minimize tearing and perforation of the sinus membrane. At this point, this is prior to me using any bio-exclude from Synoasis. So in this case, I've gone straight for PRF. This is the Chicroon APRF. I actually use it not as a membrane, but I use the raw clot. And in doing so, I can place that into the sinus cavity, and with using a relatively large tool, I can kind of spread it around. And in doing so, it seals any micro tears of the Schneiderian membrane, and also thickens the Schneiderian membrane, which means as you continue to lift, you're less likely to perforate. Now, when it came to actually grafting or augmenting the sinus cavity itself, I had to make a decision whether I'd use autogenous xenograft or allograft or a combination thereof. Now, when it came to autogenous, I don't know if you remember the cone beam, a whole lot of area to go for. And at that particular stage, I wasn't super confident and I wasn't super sold on autogenous being super fantastic. I was having excellent results with PRF and allograft and xenograft. Now, when I was in Germany, we had a lot of lectures on this particular topic, and it was found that by Dr. Stiller, actually, and you can see that article down the bottom there, that for, it was kind of frowned upon in a way. I know I'm not saying that it's wrong, and I'm not saying that there are not plenty of clinicians that aren't doing this now, where they fill the entire sinus, well, not the entire sinus, but the entire sinus volume with straight xenograft. And if that works for you, then that's great. But he was suggesting, in his paper is suggestive of this, the more autogenous that you mix with the xenograft, the better result you're going to have, because what he was finding was that the central core of that xenograft was not fully over into bone, and you might get decent insertion torque with your implant, but that was by compression of the particles more so than actually being bone with xenograft interspersed in it. For me, for majority of my grafting, I actually prefer allograft, and up till recently, that was pretty much 99% of what I used. But now I've essentially started to move back a little bit more autogenous, and I'm now doing 50-50 autogenous allo or 50-50 autogenous xeno as my ideal, depending on what the situation calls for. I use this little tool, which is kind of like a modified amalgam packer, as my initial way to introduce the graft material into the sinus. As you well know, where you cut the window and where the extension of the sinus actually is, it means that the sinus often has this mesial pocket, and it's quite difficult to access by just packing and putting the bone in and just trying to push it along. So what I do is once I've lifted that membrane, to get the bone in there just with the BioOS pen or a severed insulin needle is quite difficult. So this allows me to hook this in at right angles, really get into that little space and deposit bone right up against that wall. And in doing so, it allows the angioneogenesis to come from that wall. So I try and maximize all the walls that I have available to me. So I like to ensure that my sinus grafts are well up against the medial wall and in contact with that if I'm coming from the buccal. If I'm coming from the palatal, I want them right up against that buccal wall to ensure maximum angioneogenesis. And not only from those walls, but also from the floor and from that medial pyramidal section. So in this case, I actually decided to go for straight allograft. That was rehydrated as a APRF sticky bone. And what I did was I used that little instrument to get right up into that mesial area. And then I break it into small pieces and pack it in slowly and manipulate it as required. That's a different shot, different angle, but the same thing. Over the top, I decided to put a collagen membrane. Again, this was BioExclude from Snoasis, which is the product that I like to use both against the Schneiderian membrane and over the window these days, because it's quite thin and it's quite malleable and actually sticks to both the Schneiderian membrane and the bone, almost like cellophane. But I know that in the literature, it's statistically insignificant as long as you haven't cut up the periosteum too much, whether you put a collagen membrane or not. I just feel more comfortable that I don't want any soft tissue whatsoever invaginating into my graft. This was the closure. You can see just by the change in the soft tissue on the palate how far we needed to extend that flap. And here I've used 5/0 nylon sutures. Now, please have a look at the position of that knot, the distalmost knot on that crestal area, because you'll see at the 2-week follow-up, this caused some irritation. And this is what's led to that. And that quickly resolved once the suture was removed. Now, the best part about the palatal sinus lift is that tissue is thick. You could see from before, there we go. You can see how thick that tissue is. It's rich in blood supply. It is a really thick bandage. And most patients report significantly less pain than the traditional buccal approach. And further to this, they don't have anywhere near as much facial swelling. In fact, this patient had no facial swelling. And I did all of this prior to me introducing dexamethasone into my surgical repertoire. 6 months later, this is the post-op OPG. This is the coronal CBCT. A little bit of soft tissue, a little bit of Schneiderian membrane thickening, but that's okay. Bone is completely in contact and has turned over into bone quite nicely. I think that if I had my time again, maybe it could have been beneficial to use that Pico spur and maybe slightly decorticate that buccal portion of bone. Having said that, the bone actually turned over quite well, and maybe it would be an issue if you were to do that for fear of putting a rotary instrument into that confined space. So the benefits of the palatal approach sinus lift are or include the palatal tissue is an excellent compression bandage. You do get significantly less pain, and that's reported in the literature. A significant decrease in facial swelling. It's beneficial for denture wearers as there's no disturbance to the vestibule, and by using the denture, it actually puts more pressure on that soft tissue and eliminates any space. And it's as per the indications of a regular buccal approach. The drawbacks of the palatal sinus approach is access. Access is very difficult. The amount of force that's required to hold that tissue out of the way is quite high, and it's hard. It's hard to get your instruments up there. Visualization's hard. It's technically challenging, and you need to have the right armamentarium and instrumentation. Obviously, severing of the greater palatine neurovascular bundle, the artery, the vein, or the nerve, or multiples of these, is an issue. And hard pellet sag is something that Rado spoke about, and that was if you raise the palate beyond the midline suture, you must have a Essex, or you must have a denture or something that will compress that tissue down. Otherwise, it doesn't reattach properly, and the patient can have problems with speech, or the patients can just feel that that side of the palate, or the palate as a whole, is thicker, and it's something that they will constantly complain about. So that's something I've always been mindful of. So this is the before and the after, side by side. So you can see we've got very good volume. I was very, very happy with that. And this is what the site looked like when it was healed after 6 months. Well localized and consolidated. And a zirconia implant was placed. Another 4 months later, after an integration period, I did a modified S-flat as shown by Ricardo Kern. So essentially, the flat was cut as so. The top was, or the crestal portion was deepithelialized using a 15C blade. This was exposed, or it was lifted and then tucked into a little pouch. 2 weeks later, this is the result that we had ready for impression. If I was to do this case again, I feel as though I would have let that heal just a little bit longer to ensure that I had eradicated those little invaginations just where that incisions were made. Impression coping PA, so you can see that these zirconia implants are not bone level implants. They are tissue level implants, and they have a 1 to 1.2 millimeter collar that needs to say supracrestal. This is the crown that we made. It is a zirconia crown that is stained on a zirconia abutment on top of a zirconia crown. And the actual screw that is used is the black one. The black one there is a bicarbonate screw. And that's a carbon fiber reinforced peak screw, which you can put in and out. And as you tighten it to 25 Newton centimeters, it will slightly deform to the screws within inside the implant. So you get quite a good seal and quite a good hold. The green screw is just a lap screw. It was just there for visual effect. And that's the end of that case. So I was wondering, is there any questions that you have for me so far? Oh, I can't hear you at all. Hang on. Omid, I can't hear you. You're muted.
Oh, now you hear me?
I didn't hear, if you said anything during that presentation, I didn't hear it.
No, it's okay because I didn't say anything. but I wanted to say that, first of all, thank you for that comprehensive explanation of that technique, because you went through every details that everybody should know about that approach, and that was amazing. And one of the things that I wanted to ask you regarding the anatomical considerations in the palatal approach, you mentioned about the artery, you mentioned about the thickness of the tissue and the techniques and type of burrs that you prefer to use. But usually we have in the medial wall, posterior lateral nasal artery. Actually, I know that the part that you decided to do the augmentation was in the alveolar part, not in the medial wall of the sinus. But do you have any concern when approaching that area by putting any pressure or any tear in that artery? Because usually we don't have enough access to control that kind of complications. I'm not saying that specifically on your case, but generally speaking on palatal approaches. Do you find it something common as a complication, or practitioners should not be really worried about it?
Well, you know what, with regard to that, I'll be honest, this is not a technique that I use all the time. This is a technique I've used twice. In both cases, that would be something that I would scrutinize completely. And if you do not know how to manage those bleeds, be it intraosseous or within the soft tissue, then it's probably a technique that you shouldn't be using. You need to have multiple tools in your armamentarium in order to stem bleeding. Particularly, you know, you have to expect that you may very well cut that greater palatine artery. You need to know how to tie that off or erase it. The artery is within the sinus itself. You need to know to crush that. Are you going to be able to tie that off? Or can you, because the problem is with the artery, because it's under pressure, more often than not, when they're severed, it's like having a bit of elastic. And when you cut it, they separate. So for you to be able to tie it off is extremely difficult.
Yeah.
If it's within the bone, you can just crush that little bit of bone there and try and get a clot that way. But to try and tie it off can be sometimes very, very difficult. Mm-hmm. And that's something that you're just going to have to walk into that case with.
And Dean, one of the other things that you mentioned, actually, you talked about densobers and you talked about the transcrystal approach in such case. And your main concern was that you won't be sure that if bone forms there circumferentially on your implant. So as you know, we have some literature about it that some people place the implant, you know, and the Schneiderian membrane will be like a tent on top of the implant, and they don't even put any graft material there, but they wait much longer. So imagine what will happen in such cases that you presented, that you place your implants and imagine maybe 1/4 of the implant is in contact with the Schneiderian membrane, even if you don't densobers or even if you don't place any graft materials. So do you have any concern for long-term osseointegration of that implant? Do you think that if your sinus is clean and there is no inflammation, that little exposure on a specific surface of the implant into the sinus make it problematic in future? Or in all such cases, you prefer to go with the palatal approach and make sure the graft material is all over your implant?
You know what, that's a really good question. For me, I think that I would not feel comfortable in just having the Schneiderian membrane in contact with my implant. We know that if you're going to have peri-implantitis, it's going to go circumferentially. If it happens to go down that side and you have no bone there, no attachment, it can very, very quickly, rapidly extend into the sinus and cause you a big problem. You cannot guarantee that when you're putting your implant in, that you're not going to grab the sinus membrane and twist it all around your implant as you insert it. There's no way to ensure this. Yeah. I know that you've seen, you know, there's a number of clinicians that are just, when they do a lateral approach, they just put PRF clots inside and they don't put any biomaterial or bone substitute materials. I'm not one of these people. It doesn't suit me. I don't like seeing the implant with just this 1 millimeter or this very, very thin cortical area around that implant. I don't feel that has enough load distribution. Now, I understand that the coronal 4 millimeters of the implant takes majority of that, if not all of that implant load, but you're assuming at that point that you are not having any peri-implantitis or any bone loss. So if you have some bone loss and all of a sudden that 4 millimeters now extends into that thin area, I guarantee you that that implant will very lost.
Yeah. So your main concern is for the future things that may happen to that implant. So for making it as predictable as possible, you prefer to do the grafting and make sure your implant is completely surrounded by the bone.
Look, I think that if you have to take it on a case-by-case basis. For me, I think that if I had a few things against me, like there was a partial graft or whatever, and then I saw the big artery on the palatal, and I just didn't, I think it was going to be trouble either way, then yes, maybe I would say to the patient, look, we've got one to do this. maybe it works, maybe it doesn't. What would you like to do? And I would give the patient the onus of accepting that this is what she's presented or he's with. Because otherwise we're going to have to take it back to the drawing board, or you need to refer it to somebody who can manage all complications.
Yeah, got it.
And maybe maybe the treatment for that would be to remove that buccal bone. But for me, at this point, I would probably make that patient own the problem. So for me, like I said, I think the patient needs to, there's a big problem in dentistry is that, you know, if your implant fails, the patient comes to you and says, your implant failed, your filling broke, your filling fell out. There's no ownership of anything. So I think before I would take on that treatment, especially the way you were saying with the transcrestal approach, I would make sure the patient had ownership. I would sign consent forms. I would explain that this is not the way I think it should be done. It's just a possibility, but I would not take ownership of that.
Yeah, got it. Great point. Great point. Thank you.
No problems. Okay, so if you don't have any other questions, we can go on to the next case if you like. All right. So the next case that I've got is complex grafting using allograft. So this is a very recent case for me. And this is a case where I really had to think outside of the box. So the patient came in, she had had multiple surgeries before, both by generalists and specialists. So this is with the partial acrylic in. You can already see there's some soft tissue defects around those anterior centrals that she's lost, or the anterior teeth that she's lost. Again, this is with the implants, with the partial out. You can see here, just by virtue of the surgeries that she's had, there's marked scar tissue. You can see that there's recession on that lateral, there's recession on the canine, there's a loss of vestibulum in that anterior region. There is a lot of scar tissue, and the tissue is just really not nice. This is from the occlusal view. Again, you can see we've lost a considerable amount of horizontal bone. We've lost a small amount of vertical bone, but the issue is both the loss of horizontal, loss in the horizontal plane and loss of the vestibulum. So I know this is a horrible X-ray, but it's a reconstructed OPG from a cone beam. This was presented to me because the patient comes from interstate. This is a cone beam from the pre-op in the axial view. You can see here she's missing that upper left molar, but she's not interested in treating that as it stands. But you can see that there is a considerable loss of horizontal bone in that anterior segment. There was several attempts at grafting before, but they were grafting using alloplasts, and I just feel that the technique was somewhat lacking. So essentially they went for one particular type of alloplast. They went for primary closure. There was a whole lot of things that I feel were probably somewhat different to how I would approach it. This is a couple of pre-operative slices from the cone beam. You can see that the height is not too bad. The horizontal volume is deficient. You can see that that grafting material is inadequate, and you can also see that there's been some periapical granulomatous tissue left behind with the graft on top, which some of the graft is taken. So I essentially had to do a small little apicectomy type procedure in order to get that granulomatous tissue out. So with this patient, she was a 56-year-old female, non-smoker, non-drinker, no medication, no known drug allergies, no contraceptive pill, no hormonal therapies or hormone replacement. She has mild arthritis being her only medical concern. On examination, she was missing multiple teeth, some of the sixes or some of the first molars, and some premolars or a premolar was removed for ortho. Periodontal probing depths were within normal limits. Her oral hygiene, however, was average, I guess. Chief complaint was the missing 3 upper incisors. Aesthetic and functional deficit. She hates that partial upper with a vengeance. She has soft tissue concerns, so she is very mindful that she's lost bone over both the lateral and the canine that are adjacent to the edentulous space. She's mindful that she has recession and she can expect more recession. She presents requesting zirconia implants because she wants to have a metal-free solution because she's had some issues with metal before. Now, what made this case interesting is that the patient declines autogenous harvesting. So we know that if you had a case like this, most of the guys or most of the things that you would see would go block graft, Curie plate, full of autogenous bone, and you're laughing. You could do a Gluckman palatal block if she had enough bone, which I don't think she does. But there are a number of autogenous options which most people would feel would be ideal. And you just have to look at the work by Fuad Kur, by Frank Zastro, by Hassan, some of the guys that you've seen, and they do incredible work. Juan Chao, some of these guys do incredible work with those Curie plates, and that's something that I really aspire to. And that work really pays dividends when using autogenous. And remember I said autogenous, I was going back to autogenous. Autogenous really is key. This is my initial flap elevation. You can see here on that lateral, she does have marked bone loss, about 2/3 the way down the root, maybe a little bit less than that. And on the canine, you can also see that there's some bone loss around there. You can see around one of these sites, which has not taken. You can see next to that canine in that lateral space that again, there's alloplast which hasn't taken. And just apical to that is where you find that granulomatous mass. Here's a view once I've cleaned that alloplast out. You can see where I've done that little apicectomy. And I've essentially cleaned the bone as best as I can, removing all soft tissue tags and ensuring that I know that what I'm going to go for here is a double Curie plate using alloplast plates. So the Curie technique or Curie plate technique is a surgery performed to increase bone volume in both the horizontal and or vertical dimension for the purpose of implants. It was first described by Fuad Curie in 2007. And whilst autogenous has been long considered the gold standard, and for me, in my eyes, it still is the gold standard, allograft products are actually becoming quite promising, and there's a number of articles showing that. So the indications for allograft augmentation are the same indications as autogenous. Having said that, I would go so far as to say that one must graft a greater volume if you're going to use allograft over autogenous. I don't feel in my hands, or I generally don't feel, if you're using straight allograft plates and allograft bone chips, that you're going to get as good a bone volume as you would with straight autogenous plates harvested. The other indications for allograft plate augmentation are inadequate bone or unfavorable anatomy for harvesting, and that might be because the patient's had bone harvested before, or just the way their anatomy is, or the IAN is quite close to the buccal area. Also, like in my case, the patient refused harvesting. Now, the other reason I see a lot of people starting to use this is that many people are uncomfortable doing the harvesting from the ramus or from the chin or whatever when you want to get blocks. For Curie plates, a lot of the people are going for ramus, and that bone is really quite good. But people, I feel, comfortable doing these harvesting procedures, or they don't have the correct armamentarium to do it, and it is easier to buy an alloplast plate. Now, I will stand, yes, I used the alloplast plate here, but if I had my choice, I would have absolutely gone for an autogenous plate with autogenous bone. This is the allograft cortical plate that I used. You can see I've rehydrated that. I actually rehydrated this both in metronidazole and, funnily enough, Emdogaine. Now, there are two schools of thought. Some people decorticate, not decorticate, but actually put holes through these plates to try and get more blood perfusion. I actually did not in this case. The other part of the procedure, or the cocktail, I guess, was I used these allograft cortical pins. The patient wanted to have as fewer screws as possible, so I actually used these cortical pins. So that's like I think it's a 17 millimeter rod made out of cortical bone, like a dowel, I guess. Here, I did all my measurements for for the bone volume that I. You can see that I've decorticated the native bone at the recipient site, being mindful not to prang the teeth adjacent. I decorticated as much as I could, and when I decorticate, I actually like to use TMS pin drills because they have a guaranteed stop. I've been told off before for using too large a burr size. Having said that, if I'm going to do a straight block, I would like to completely take off any cortical bones. So that way I get as much angioneogenesis from the rich cancellous bone underneath, if I can afford to do so. Obviously, it's not going to come at a cost of stability of my plates or my block. And also, I don't want to take off so much bone that I'm left with very, very little. In this case here, I used those sites where I did the apicectomy and I had to remove some of the alloplast as spots for the tenting of my cortical pins, and I put them in using a 2mm twist drill with a stop. As you can see, they've got these little grey markings on them. That's from a surgical pencil, so I could measure them outside of the mouth and put them in where I wanted them to be, and then take them in and out, bevel them, and do all the sort of things that I needed to do using an array of discs and burrs. I've measured using a perioprobe that I'm going to ensure that I'm going to get the bone volume that I want in order to ensure that I have greater than 2mm of bone as my final product. Now, as I said, I like to overgraft when I'm using allograft. I think you're going to get a little bit more bounce back than you would with straight autogenous. So this is my estimated horizontal volume. That's without the lid, obviously. And essentially, these cortical pins were essentially just there as pylons, I guess, as just to hold up the cortical plate in addition to the screws. In doing so, I could keep the screws as incisal as possible, as coronal as possible. There you go. There you can see I've tried the plate in, and you can see the volume of space that I have underneath. Here, all the plates must be held down with a minimum of 2 screws, and those, with this particular case here, you can't, on the underside of that allograft plate, I've used a round burr and cut a half circle such that my pins sit inside that circle so that the plate moves even less. And then I've held that down with screw pins from Profix, so these bone screws from Profix. And you can see there, I've filled that with a PRF rehydrated sticky bone allograft 50/50 cortical cancellous bone. Now, you'll notice that it's bleeding a lot. And the reason I did that, or the reason that's happening actually, is because I've soaked that plate in Emdogain. I put Emdogain on the adjacent teeth, and with the sticky bone, I put a little, whatever was left of the Emdogain on top of that. And I just find, incidentally, that Emdogain just seems to draw blood out of the native bone or the host bone of the recipient side. So if I have a case where I'm going to put an implant in and I know it's going to be D1 or D2 bone, and I do my osteotomy and it looks really cortical, and this is something you should probably be able to see before you do the implant with your cone beam and things like that. I will put Emdogain in and around that implant, even in the osteotomy, and watch, even in dense cortical bone, it will draw blood into that osteotomy side. Here, you can see that I've placed the plate on the patient's left-hand side, but on the right-hand side, I've just pinsed as instead of tenting screws. And you can see that here from the lateral view. And you can see this here from the occlusal view and a close-up of that. And I know there's lots of blood going on, but it was very difficult to control at this point. Now, the reason that I did say at the start that I went in there hoping to do a double plate, and you can see the left side got the plate, whereas the right didn't, is because I dropped the plate that went on the right-hand side. So essentially what I have here is a split mouth design. So what I did was I used those cortical pins as tenting screws, and I covered the right-hand side. I put my allograft there. I covered it with Ossix bone, sorry, Ossix Plus, the collagen membrane, the ribose cross-linked collagen membrane. And on the left-hand side, I did my allograft Kuru plate. And this is the room. You can see here, in fact, what you can't see is I've put my collagen membrane over the whole lot. I've put a Snoasis Bio Exclude, which is amniotic chorion membrane. And I love them because they're super, super thin. And obviously on top of that, I'll put a little bit of the PRF membranes just so I can get some really good soft tissue closure. I don't think that the PRF membranes do very much for the bone. Having said that, I'm not Rick Myron, and I think that that's another course that I'd like to get to at some point. Here, what you can see is I've done with regards to PTFE, I like the fact that they're non-resorbable. I like to ensure that my things are tacked down. And the combination of the sutures that I've put in is I have done two vertical horizontal mattresses in a vertical direction. So going from deep in the vestibule over the top and out the palatal, and that's to hold my membrane down. I've done a big horizontal one going from the first premolar to the canine on the other side, holding things down horizontally. And then as you can see, deep in the vestibule, I've done those deep apical mattresses. And the whole purpose of those sutures, as described by Shakroon, is when you put those sutures in, which go in through the buccal, out through the palatal, back in through the palatal, and then come out through the buccal again. When you tie that, the soft tissue, everything apical to those sutures does not, you can move it as much as you want, and it has no impact on your flap. So I can pull the lip around as much as I want, and there is no tension, there is no pulling on my flap. After this, I've just done a series of simple interrupted to close the vertical releases. I've done a couple of vertical mattress sutures on the crest. And I know it looks like a great big mess. And at this point, it looks muddy and it looks like a great big mass. Having said that, it's all tension free. And when the patient returned 3 weeks later, which was actually not that long ago, a couple of days ago, this is what we found. It all healed very, very nicely. So the patient's happy. She's in no pain. There was no swelling, no pus, no pain. We did get a little bit of a recession as to be expected around that lateral and a little bit around that canine, but that was all explained pre-op. And this is prior to the suture moved. This is after the sutures have been removed and she looks like she's got a bone tumor happening underneath there. And if you actually look, I think that yes, I remember I told you when we're using allograft that you need to overbuild. So I know that if I do get some recession of that bone, it will put me in a really good standing with regard to being able to put my implants in. So this is the pre-op occlusal view. This is the pre-op occlusal view minus the vestibule. Okay. Then if you take that pre-op occlusal view minus the vestibule, and you can see what we've done, or what we've put in there. Sorry, it hasn't matured yet, but it's looking very good at this point. So that's the before and then the after. And that's to be continued because she's only a month into healing. So I will definitely be giving you a follow-up on those. If anyone wants to contact me, by all means, there's my contact details. And now it's over to you, Omid, for some questions.
Oh, wow. It was amazing. Could you please keep that information of your contacts on the screen so that participants can see it during our discussion, so they can have the chance to be in contact with you?
How's that? Can you see that clearly?
If you maximize it, it will be better. Yeah, good.
Okay.
You know, and I really like this technique that you showed, and something that is really interesting about those cortical rods. First of all, I want to know if they're what company provides them, because maybe it will be a question of so many people. Is it only in Australia, or is it something that we can find in the US?
No, Salvin.
Oh, it's by Salmon, because I didn't know.
It's from Salvin.
Yeah, you know, because the way that you
Yeah.
described it, I think it can be a good substitute for 10-pole technique with those cortical rods, because the difference is that in 10-pole technique we need to remove those screws, and sometimes, you know, there will be a hole between our graft materials of that screws. But when we put those cortical rods, so it will be there. There is no need for removal, and I think it's a great concept. And the same rationale for that is that it prevents the pressure from the flap on our graft materials, so we have a space maintenance and more bone formation. So that was a great idea. Also, I want to know about those two screws that you added to the plates. With those two screws, I want to know that when you decided to screw through the allograft, was those screws completely integrated with the plate, or they went through the plate passively? I want to know the head of
No, I always put it through through the plate passively.
Passively. So no pressure on the.
Yes, I don't want to engage. If you do that, the plate will crack.
Mm-hmm.
So I make sure that the hole is bigger, and then that way, what's actually holding that plate down is actually the head of the screw and not the threads of the screw. Because if it's the threads of the screw, we want to just go and do this, and inevitably the screw cracks, the cracks and breaks. And I've done that so many times. Ask me how I know.
Yeah. And Dean, one more thing that I wanted to ask you about these cortical rods. If you want to compare using this kind of 10-pole techniques with Khoury technique like autogenous plates or allogenic plates or whatever, and compare it with very narrow titanium plates that are available in the market. So instead of having a plate like autogenous or allogenic or whatever, you place those narrow titanium plates and fix it with the screws to provide the space. Do you find any difference in your experience with these kind of techniques? Because in general, all of them are keeping the space, and you know, the point is to reduce the pressure from the flap to the graft material. So I just wanted to know your thoughts on that.
You know what? I use titanium meshes a lot, and then I went off them for a long time when I discovered Khoury plates, and then I spent some time with Ehab Musa, and I got back into the Thai mesh, and I just feel that for me, in my hands, Khoury plate autogenous is the best, and then us will be a close second. Now, if I had to do this case over again, the only thing that I would definitely do differently would be I would make holes inside the plate and use the screws. So I would make the holes such that the plate is press fit, so that the dowel puts a little bit of pressure, and as I put the plate on, it just pushes on, and that way the tension from, or the grip from the pin hold the plate on. That's what I do. And that way I don't need to remove the screws, and that way I don't need to raise a flap, and I don't need to remove the periosteum from this bone, because we know every time that we remove the periosteum, you're going to lose a percentage of that bone. So, you know, with allograft, I want to keep as much as I can. So this way, I think by doing that, I have to expose the flap, even if it's split thickness or not. It's just not nice to cut such a big flap.
So, you know, actually that's true. But my question is also on that, because you use those tent poles in right and left side, but in left side of the patient, you use the plate, in right side.
Yeah.
What's your prediction now? Do you think that the amount of bone formation going to be different in right and left? Or you think that those tents are doing their best jobs, you know, and that plate maybe not necessary in this procedure. What's your prediction on that?
My prediction is going to be that even though the patient is absolutely fantastic and is extremely compliant, and she no longer wears her denture, and she's just a really, really compliant patient, I don't feel that we have as much bone on the right as we will on the left.
Mm-hmm.
The left allows the plate, prevents any dispersion of those particles. Is here you've got on the right, you've got just those cortical pins and a collagen membrane. Even though the collagen membrane, the Ossix Plus, is held down with a hash, like a hashed suture, it's locked down horizontally and vertically. I still feel there can be some graft movement. I still feel there can be some particulate dispersion, and in such, I predict that you will not have as much bone volume on the left as you will, so as much on the right as you will on the left.
Wow. I truly looking forward for that re-entry, because that's a $1 million question, I think.
That makes it.
Yeah, and because if it works.
But we have what we have here.
Yeah, go ahead.
No, you're right. If it works the same, well, you've proven something. But what we have here, like you said, is a single patient, I don't know, split mouth design.
Yeah, you're right. We need more follow-ups, but because you mentioned Joseph Chukroun, because he also is a great fan of using only tenter screws and no nothing, because he believes that pressure is the only thing that will minimize the bone formation rate. And by those screws, name it 10-pole or whatever, just because you're reducing that pressure from the flap, there's a space for bone formation. And that was why I asked you the question, because you showed both scenarios in one case, and that was really interesting. And I have to say, for all of our audience, please follow Dean's Instagram page. He posts beautiful cases from his skills, which is superb. And you can follow also this case on his page. I have to say, I truly enjoy your presentations all the time. Big fan of you, my friend. And so thankful that you accepted to join, and really looking forward to seeing you soon in person, hopefully in Iran or in Sydney, wherever in the world. And thank you again for your time. I truly enjoyed.
Absolutely. Thank you very much for having me. I was really concerned about being able to put up something. I know that you've had some absolutely stellar guys on the hot seat, both in season 1 and 2. And I'm like, how do I compare to these guys? What am I going to say that's going to be worthy of anything? So hopefully I've given your audience something worth listening to.
It was absolutely like that, because your cases, the topic and the way that you presented was amazing. And I'm pretty sure everybody enjoyed every second of it. Thank you so much, Dean. Thank you.
Thank you so much. It was great chatting to you.
Take care, and hats off.
I hope to see you in person soon.
Sure.
Bye for now.
Bye.